All right, in this video we're going to talk about blood pressure. This is the last of the information in this chapter 15 that will be on the test. The rest of this chapter goes over arteries and veins and names them, which is more lab information. But as we go through, most of us know what blood pressure is or have heard of it, right? We know general ideas of it. 120/80 is normal, but a lot of people don't necessarily know what that is, what that even means, and what it's measured in. So the blood pressure is simply the force the blood exerts on the inner walls of the blood vessels. Blood pressure circulates the blood because it's the pressure, the high pressure that is created in the contraction of the ventricles that pushes the blood out to either the lungs or the body. Now, when we talk about blood pressure, it is pretty much almost entirely about what's called systemic blood pressure, or the blood pressure in the systemic arteries. Now, remember, we have two circulations. From the heart to the lungs, and then from the lungs back to the heart, and that's called the pulmonary circulation. And then we have the heart to the body, and then the body back to the heart, and that is called systemic circulation. So the blood pressure refers to the particular part where the blood is being pushed away from the heart to the body. All right, so got to know that it's a pretty specific thing. Now, there is blood pressure throughout the whole vascular system, but most of it is very low. And blood moves from higher to lower pressures throughout the system. That's the way everything in the body necessarily works, whether it's high concentration to low concentration or high pressure to low pressure. So arterial blood pressure, when the ventricles contract, it is going to cause an increase in pressure. When the ventricles relax, it causes a decrease in pressure. So when we're looking at something that says 120/80, the 120, the high pressure, is when the ventricles contract. The low pressure is the pressure in the system when the ventricles relax. So systolic pressure is the maximum pressure reached during the ventricle contraction. Again, this is left ventricle contraction. Again, when the school opens back up, I'll try to see if I can get one of those computers that has like a pen where you can draw on it. But anyway, systolic pressure, which is the high pressure, 120 in this would be systolic pressure. Now, in a previous video, we went over that systolic means contraction, diastolic means relaxation. So systolic pressure is the high pressure, diastolic is the low pressure. Now, we have what's called a pulse pressure, which is the difference between these two. So let's say a normal, going up here to the normal, the pulse pressure for this would be 40, right? 120 minus 80. That would be the pulse pressure. And we want things to be roughly around this 40 range. If the pulse pressure starts getting higher, that means that the wave is larger. So if you're out on the ocean and you've got 2-foot waves, if all of a sudden we have a storm and we have 6-foot waves, that's when we see beach erosion, right? So when we increase this pulse pressure, those waves of pressure are going to crash into that capillary bed, the real fragile tissues, and can cause damage. Now, mean arterial pressure, okay, mean is an average. Mean arterial pressure is when we take the average force driving blood to the tissues, which is the diastolic pressure, plus 1/3 of the pulse pressure. So when we're looking at this, all it's saying is I'm going to take this pulse pressure, I'm going to divide it by 3, and then I'm going to add it to the diastolic pressure. And that's just kind of saying that we're looking at the average force driving blood to the tissues. Now, another thing to remember, and this is also a pretty important thing in lab, that the blood pressure is measured in what's called millimeters of mercury, mmHg. This is the old school way that we would look at things, but it's still the way we measure it now. So if you've heard 120/80 is the normal blood pressure, it is 120 millimeters of mercury as a pressure over 80 millimeters of mercury. Now, a couple of things, and this is always a really fun one right here to go over. Sphygmomanometer, all right? The word sphygmomanometer is what this puts as an inflatable cuff, a blood pressure cuff. You do need to know that the scientific name for that is called sphygmomanometer, all right? So when we're doing this, and unfortunately, again, in lab, we usually try to partner up and learn how to take blood pressure. Blood pressure is a very important thing. I will tell you that it is one of those things that really upsets me how many students and nurses just become lazy on blood pressure. Being able to take a good manual blood pressure is a very, very, very important thing. Now, blood pressure, as you're going to look here, this is the pressure as it's moving through the system. So as it's going from the heart, right, and away from the left ventricle, as it says here, this is going to show how drastically the blood pressure is going to decrease. And you'll see that not only does the blood pressure itself decrease, but it's going to merge there. Once we get into the capillaries, there is no longer a difference between the high, the systolic, and the low, the diastolic. It just becomes one pressure. Now, these are areas that are called pulse points. The pulse points are going to be areas where you can find an artery that is close enough to the surface that I can feel it, but yet there's something solid, a bone underneath it that allows me to put enough pressure on it that I can feel that wave as it goes through. Now, there's plenty of these. The best by far is the carotid. Inside this little area where you can see there will be a little opening where you've got the trachea and you've got the sternocleidomastoid that goes through, a little indentation that you can put your fingers in there and you can feel the carotid pulse. By far the best one to use. The most common one is this one at the radial. Now, again, I don't know about this picture. The picture should be a little bit closer over here because it is at the base of the thumb. The radial artery, we're going to look at naming these in lab. This is going to be very close. This is very lateral. It's very close to the base of the thumb. Now, again, in lecture, if we were able, or in lab, if we were able to meet, it's easy to show how to do this. One thing to make sure you understand when taking a pulse, you never use your thumb. The thumb has its own pulse to it, so you never use your thumb. You're generally going to use your first two fingers here. And for instance, for the radial artery, if you're going to take it, you're actually going to kind of put the first bit of light pressure very lateral and actually roll in medial to kind of pull the tissue out of the way so you can feel that pulse. Now, one of the ones that's more clinically significant is this duralis pedis. The duralis pedis is one of the farthest pulse points away from the heart, and so it is very clinically significant because we're going to test a long amount of cardiovascular vessels, so the cardiovascular system, so you can test it really far down. Now, one thing is when you start losing some pulse, you start having cardiovascular issues, you're going to have trouble getting blood down to your lower extremities and actually pulling it back up. One thing to always look for as a nurse, if you've got someone that's in a hospital bed and you're monitoring them, you first look for a loss of hair in the lower extremity. But you want to, if you're really worried about them having some cardiovascular issues, you kind of want to keep an eye on this duralis pedis pulse, and you want to do it bilaterally. So these three, this is the best by far, this is the most common, and this is the most clinically significant in someone. Now, a lot of these places are fairly easy to get to. I will tell you, this one here is one that you do not want to do by surprise. If you have a patient and for whatever reason you want to test the pulse at the femoral artery, if they are conscious, you need to make sure you tell them what you're doing. That is not a good surprise point. So when we're talking about blood pressure, there's a lot of things that go on. This is a big wrestling match in our body trying to keep blood pressure normal. And so we're going to look at a couple things that are going to affect it. One is if the blood volume increases, right? So if you are drinking, if it's happy hour at the bar and you're pounding back your sweet teas or, whatever, any fluid you take into your body is going to be eliminated, but it first has to go through the cardiovascular system to get to the kidneys, to get filtered and get out. So if I'm drinking a ton of fluid and I'm not sweating, I am going to increase my blood volume until I can get rid of that through urination. And it can be very deadly. I've seen people carrying around like a gallon jug of water and they'll constantly drink on the water through the day. If you drink that too fast, that's a problem, because if you do, it's going to go into the circulatory system. It's going to increase your blood volume, which is going to increase your blood pressure, and that could be a bad thing. There are people that have died from drinking too much water too quickly. Another thing that's going to increase blood pressure is an increase in heart rate. If I'm exercising, I'm going to want to get more blood out to my body to get that oxygen out there. So if my heart rate increases, my blood pressure increases. Now, if my heart rate decreases, my blood pressure will also decrease. So it's kind of it works together, as well as this one, stroke volume. Stroke volume, again, kind of goes with heart rate. Stroke volume is the amount of blood that's ejected every time the ventricle contracts. So if I increase the amount of blood that the ventricle is putting out, I'm going to increase the amount of blood inside the circulatory system. So that's going to, in the systemic arterial portion of it, that's going to increase blood pressure. Now, if I go down to this one, peripheral resistance increases. Now, this is a fancy way of saying another fancy thing called vasoconstriction. So if all of a sudden my blood pressure drops, for instance, if I have vasoconstriction of my arteries, I'm going to increase blood pressure. And I'm doing that because I'm increasing peripheral resistance. Now, that is a normal way to do it. There is an abnormal way that increases peripheral resistance, and that is atherosclerosis. If I have plaquing inside of my blood vessel, so if this is a normal blood vessel, and all of a sudden I start accumulating some plaquing in here, I have decreased the lumen size, the size that the blood's flowing through. That's going to increase peripheral resistance, and that's going to cause an increase in blood pressure. And then I saved this one for last because I wanted to show these three here. All right, I can tie them together with a little string. These three here can go either increasing or decreasing. If I increase heart rate, I'm going to increase blood pressure. So if I decrease heart rate, I decrease blood pressure. If I increase stroke volume, I increase pressure. If I decrease stroke volume, I decrease pressure. Peripheral resistance. If I increase peripheral resistance, I increase blood pressure. If I decrease peripheral resistance, I decrease blood pressure. Those three kind of make sense. Now, these two are two sides of a different coin, of the same coin, I should say. But they have the same result. So if blood volume increases, right, in general, that means that I'm overhydrated. I've put too much fluid in, and I'm going to increase my blood. Now, if blood viscosity increases, if blood gets thicker, which means I'm dehydrated, I'm going to increase blood pressure. And that happens because the thicker fluid increases peripheral resistance, right? So let's say I've got 3 cups in front of me. One is a cup of water with a straw. One is a milkshake from, Hardee's, with a straw, and the other one is a Wendy's Frosty with a straw. And none of them are melted. You can tell the difference between trying to sip through a straw, the water, the regular milkshake, and the Frosty. Because the thicker the substance that I'm going to pull through that straw, the harder it is. And that is exactly what blood viscosity is. If I start increasing blood viscosity, which is another way of saying blood becomes thicker, then it's harder to push through the tubes, which means it increases blood pressure. The reason that blood will become thicker is because that ratio of 55% plasma, which is mainly water, and 45% formed elements starts changing, and I start losing this percentage of water, and that's going to cause the blood to become thicker. So we'll look through these. Cardiac output. Now, cardiac output is how much, right, the volume of blood, how much blood is pushed out or discharged from the ventricle each minute. Cardiac output takes the stroke volume, which we looked at just a minute ago. Stroke volume is the volume of blood that enters the arteries, or said another way, exits the ventricle after each contraction. It is roughly about 70 milliliters per minute. So to find the cardiac output, we take the stroke volume and multiply it by the heart rate. Now, heart rate is simple. I find a pulse point. I'm going to palpate it when I find the pulse. You can do it several ways. In general, most people will find the pulse. They'll count how many pulses happen in 15 seconds and multiply it by 4. You could go straight to feeling it across a minute. That's great. You could do it by 30 seconds and multiply it by 2. Whatever it is, you find the heart rate, which is simply how many beats per minute. Now, this is kind of interesting. Cardiac output is, on the average, 70 milliliters per beat and 72 beats per minute, which comes out to roughly 5 liters, a little over 5 liters per minute. Now, the average person has 5 liters of blood in them. So, in general, every minute, your blood, the blood that is being pumped out of your heart, is coming back, in general. So, I always think that's pretty interesting. Now, blood pressure varies with cardiac output, of course. So, if I start increasing cardiac output, I'm going to increase my blood pressure. Increase in stroke volume or heart rate causes an increase in cardiac output, which increases blood pressure. These say, it uses kind of repetitive words that get kind of confusing. Basically, if my heart is beating faster, I'm putting more blood into the system. If my heart is putting more blood into the system, I'm increasing blood pressure. So blood volume, we talked about this, the sum of the volumes of plasma and formed elements. On average, it's usually about 5 liters for an adult, 4 to 5 for female, 5 to 6 to male. And I said this at the very first one, the very first video, the most accurate way to tell blood volume is a percentage of body weight, and it is 8% of your body weight. So the blood pressure is directly proportional to blood volume. So if I increase, I'll do it this way. If I increase blood volume, I increase blood pressure. Any factor that changes blood volume changes BP, or can. Your body might react to it to monitor it to try and keep it level, but it will change it. It's homeostasis that will try to keep it level. So decreased blood volume due to a hemorrhage decreases blood pressure. Now, this is exactly what we're talking about with the direct proportional of blood volume for blood pressure. Now, what happens is if I decrease blood volume and my blood pressure decreases, my body's going to go through a series of reactions to cause vasoconstriction, or have a thirst reflex that'll kick in, that'll make us want to drink water, all these things to try and counterbalance that, to bring the blood pressure back up. Because blood pressure too low is bad as well. Just as a little FYI, I had another professor. When I first started teaching here, there's a professor across the hall from me and she was talking about how she had just gone to get her eyes checked, and they had taken her blood pressure while she was there. And her blood pressure was, and I want to say it was like 60 over 40, and she was all excited about how great that was. And I'm like, first of all, you need to sit for a second, because if that's true, you should be dead. Second of all, I don't know if you need to get your blood pressure done by an optometrist. Now, that's nothing against them. I'm just saying that, man, it's hard enough to get a good nurse in the medical field to know how to do it. But anyway, it turns out they took it wrong, and she was fine. But it was weird to see how people think, well, if high blood pressure is bad, then low blood pressure has to be good. And that's not true. Low blood pressure is very deadly. So peripheral resistance, this is simply the force of friction between the blood and the walls of the blood vessel. It has to be overcome for the blood to flow. Obviously, if I have resistance of, let's say it's 10, we'll use the millimeters of mercury. If I have a resistance of 10 millimeters of mercury, anything that's below that will not get past it. So in order for blood to flow, blood pressure has to overcome peripheral resistance. There's a lot of factors that change it. Again, vasoconstriction is a big one. If my blood vessels close down or get smaller, that's going to increase blood pressure. So now when blood is pumped out of the ventricles, arteries swell. Rapid elastic recoil sends the blood through the arteries against peripheral resistance of the arterioles and capillaries. Now, this is an interesting thing. So if I have, I'm just going to draw it in a straight line here. If I have, and look at our aortic semilunar valves here, and I'm going to draw 3 of them here. And this is the line. So this is the ventricle here. As the blood gets pushed out, it's going to meet resistance from all the blood that's here. And it's going to come back and actually hit against this valve. Now, that's going to help push the blood into the right and left coronary arteries. But the other thing it's going to do is it forms a trampoline effect of pushing it back in. There's an elastic recoil that sends the blood, that helps push the blood to overcome the peripheral resistance. Now, viscosity, which is simply the measure of thickness. That's why, if you remember, not too long ago in 210, you learned that the vitreous humor, the fluid in the posterior cavity of the eye, is this thick fluid. Viscosity is the same. The root word, it means thickness. Viscosity, the thicker a fluid, the harder that fluid is to move. Again, the example of the 3 types of drinks. So the greater the resistance, the greater the viscosity, the greater resistance. So the blood cells, which are the formed elements, and the plasma proteins increase the viscosity of the blood. The greater the resistance to flow, the greater the force necessary to transport the blood, the greater the blood pressure becomes. So if I have some atherosclerosis, which is going to increase the resistance, I'm going to have to increase blood pressure. If my blood becomes thicker, it's going to increase resistance, so I have to increase blood pressure. Any factor that alters the concentration of blood cells or plasma proteins also alters blood viscosity, right? So if I am dehydrated, that's going to increase the concentration of the formed elements, which is going to increase viscosity. So anemia lowers concentration of blood cells. It lowers blood viscosity, so it lowers blood pressure. Now, that's a bad thing. Now, blood pressure. Now, I'm going to break this up and look at it in 2 cycles, because I don't know that this kind of shows up as well. But again, this is a really, not only is it important to know, it's actually pretty amazing what goes on. Now, back a long time ago in 210, in a galaxy far, far away, we learned that there was something called homeostasis, and we have 3 parts to it. We have a receptor, a control center, and an effector. All right, and then we learned later on that in the simple reflex arc that we have kind of the same things, and so this would represent the sensory Neurons, this would represent the motor neurons, or afferent neurons and efferent neurons, right? Whoop, no, it's like a B. Anyway, hopefully you remember all that. But blood pressure is determined by cardiac output and peripheral resistance. Boom, boom, boom. Maintenance of blood pressure requires regulation of these two factors. So the next slide, we're going to look at what happens when blood pressure gets too high. All right, I'm going to have something happens, whatever it is, my blood pressure is going to increase. Now, earlier we talked about two areas where your body is constantly monitoring blood pressure, the aortic arch and the carotid sinus. So these notice that there's an increase in blood pressure. This sends a signal, boop, 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 to the autonomic nervous system, part in the medulla oblongata, part in the hypothalamus. Those are the two big areas of reflexes, homeostasis. So we're going to send a signal. One's going to go out to one of the things that's going to be used to help it is peripheral resistance decreases. This is called an effector. So I'm going to go to my arteries and I'm going to cause them to vasodilate. That's going to decrease resistance, and that's going to decrease blood pressure. The other effector is going to be the heart. Heart rate will decrease. That's going to cause stroke volume to decrease. Cardiac output decreases. And so blood pressure decreases. And then we're going to have this return back to normal. If it is too low, same thing. I'm going to have my little receptors at the aortic arch and the carotid sinus. They're going to notice that I've got some issues because my blood pressure is going down. They're going to send a signal in through the nervous system to the same two areas, hypothalamus and the cardiac center of the medulla oblongata. These are going to activate effectors, right? Effectors are what are going to be used to change things. One of the effectors, again, is blood vessels. They're going to vasoconstrict. They're going to get smaller. That's going to increase blood pressure because it increases resistance. The other effector is the heart. It's going to increase heart rate, and that increases stroke volume, and that causes the cardiac output to increase, and then again, increases blood pressure, and we get back to normal. This is going on all the time. Now, this is one thing I want to point out, that when we have high blood pressure and we try to take medication to lower it without it being natural to our body's going to respond to it as if our blood pressure has lowered. So even if, let's say, we have super high blood pressure, 170 over 100, boom, and I lower this, even though that's good, my body's going to think of it as something's wrong, that this is normal, and the medicine I'm taking is altering it to help bring it down. And so our body recognizes a problem. So one of the things, if you've ever heard of the ACE inhibitor, it's an inhaler, we're going to take that stops a conversion here, and it stops my body from causing the effectors, the blood vessels, to constrict. Another thing that we do, we'll take beta blockers that are trying to stop the increase of heart rate, because our body's going to use the sympathetic nervous system, and it is adrenaline or epinephrine that's going to go to the heart and cause it to constrict, and the adrenaline, epinephrine, binds to beta receptors. So if I have a beta blocker, it blocks it. Right? So most things that we're going to see trying to regulate blood pressure to lower it is going to affect this natural cycle. So this is kind of given a flow chart of how things go through. I'm not going to go through it step by step. I want you to look at it. It's not necessarily something I'm going to test you on, but if you understand this, you understand the basics of all that we're talking about here. Now, one of the last things is talking about how, because the venous system, the blood pressure is so low, it is very hard for the body to get the blood back to the heart. And so the blood pressure decreases as blood moves through the arterial system into the capillary network. So very little pressure remains in the venous end of the capillaries. And so once we get this venous flow, that's why we have these valves here, so that when we're pushing blood back to the heart, they have these little department floors, I guess. You know, it comes up and it relaxes on it, squeezes, pushes it up. So this is what this picture is showing, that veins are going to really try to run through. When you look at them, you'll see that they run through skeletal muscle. Skeletal muscle is going to be on either side of them. So that as the skeletal muscle contracts, which is on this one, it's going to squeeze and the blood's going to be pushed up to the next level, and it can't go down to the one below it. And so when it relaxes, the blood's going to pool here, and then when it contracts again, that blood that's here gets pushed up to the next one. Skeletal muscle, and then breathing does it. And breathing does it because I'm going to increase and decrease the pressure inside my thoracic cavity. So inside my thoracic cavity, there's not a lot of muscles for the veins to run through, but I can change the pressure in there, which is exactly what the skeletal muscles are doing. And so that's going to help push that blood back in. Now, there is a slight bit of ability for the veins to vasoconstrict, and this is going to help push that blood into the circulatory system. We talked about, or through the circulatory system, we talked about how the veins are the blood reservoir. So what happens is, as I start exercising, my skeletal muscle contractions increase. I start breathing heavier, and I'm also going to use the little bit of smooth muscle that I have in here to vasoconstrict. That takes that 60% that we looked at of blood that's in the venous system and push some of that into the arterial system to start bringing that good O2 out to our cells.